All right, just going to cover some basic topics like definition, causes, pathophysiology, diagnosis, and management. So the definition of crush injury is a direct physical injury resulting from an external force, whereas crush syndrome is a clinical syndrome caused by blunt injury to skeletal muscles with subsequent systemic effects of traumatic rhabdomyolysis. Rhabdomyolysis basically means dissolution of muscle. So you'll get myoglobinuria, elevated creatine kinase, metabolic acidosis, fluid electrolyte abnormalities, and variable kidney injury. The causes of traumatic rhabdomyolysis is usually entrapment from a building collapse, assault from a shambok, severe blunt trauma from an MVA or PVA with or without fractures. And then you also get muscle hypoxia with prolonged pressure seen in elderly that fall and can't get up, or major vascular injuries. I spent more time on all these little slideshows with the blocks falling than most of the slideshow. So we had a major disaster incident this year with the building collapse. It was many patients had died in this case. And in the report here, our death toll 27. I don't know what the total amount was, but the estimated amount of people on site was 81 and the rescued was 56, which overall is pretty good. So if you look at mass casualties, they say that 80% of the entrapped victims usually die from severe injury, and then while 10% sustain crush injury and 10% mild trauma. And of those 10%, 40 to 70% have crush syndrome. So when you think of these larger areas, it's actually a large percentage of patients that end up with crush syndrome that we often miss. The non-traumatic causes of rhabdomyolysis, drugs and toxins like alcohol and statins, significant exertion from exercise or seizures, and then other things like heat stroke, hypothermia, infections, and so forth. This is also a broader example. I'm not going to go read to it, such a busy slide. The pathophysiology, it's not usually directly due to muscle ischemia, but it's due to an overstretched muscle sarcolemma, which causes permeability to then increase. And that causes an influx of water and extracellular calcium into the sarcoplasm, and that results in cellular swelling, increase intracellular calcium, disrupt cellular function, and decrease ATP production, which resulted in the death of the cell. So to explain it more easier, the slideshow was actually given, or the video was actually given by Ansha from a person called Ben Tissy. It's a TikTok from them. So what he's described here, it makes it so simple. Say your sponge is representing the muscle, and the yellow fluid is the bodily fluid surrounding the muscle. Now, if you put a force in it, a crushing force, myoglobin and electrolytes will leak out from the muscle into the vascular system. And once that pressure is released, you can see how the sponge is now reabsorbed that fluid back into itself. Draws up the fluids from the surrounding fluid and draws it up, causing hypervolemia, which is third space losses, and the electrolyte disturbances. So some of the effects of the myoglobin that is now circulating through the system, they precipitate and they cause obstruction to the renal tubular flow, and that's a direct toxin to the renal tubular cells. Because in this basic schematic that you see here, you look at the kidney side, you see the myoglobin is disrupting the distal renal tubules. Metabolic derangements that you can get from crush, hypervolemia, which we've already established, hyperkalemia, hypocalcemia, hyperphosphatemia, metabolic acidosis, and myoglobinuria. And just to break it down even further, potassium, obviously hyperkalemia, which will cause you to have cardiotoxicity and provoked also by hypocalcemia and hypervolemia. Your phosphate, again, hyperphosphatemia, metastatic calcifications, which is calcium salt that are deposited in your vessels. Myoglobin, creatine kinase will go up, your thromboplastin, which can lead to disseminated intravascular coagulation, and your organic acids, which causes metabolic acidosis and aciduria, just a contributing factor to that. The diagnosis here, history of trauma is obviously the most important for crush syndrome. Your urinalysis will show myoglobinuria, your CK levels, which we'll touch on now, your venous blood gas, which will show in a metabolic acidosis and a low bicarbonate, and a classical Coca-Cola colored urine, which everyone likes to describe. So crush syndrome, again, there's tram track lines, there's pathognomonic of a patient with significant injury that could indicate crush syndrome. Of course, the building collapse is very important that we rule that out. And don't forget about these old ladies that fall. These buggers, they fall down and hit their legs hard. And what happens is they have a prolonged time where they are down on the ground and they're calling for help, but no one's helping them. And that pressure can result in tissue death and crush syndrome. I've been caught out once, and I was starting off here. Referred a case of an old lady with crush syndrome, and I thought, no, it's probably, she's dehydrated and not getting enough fluids while she was down. But actually, because of that pressure, she was lying down with a femur fracture. She actually had crush syndrome. The creatine kinase was significantly elevated, and she had acute renal injury.
I think there was a lady in ICU the other day. She fell from a height. I think it was an ortho patient. Was it you, Shane? And then there was also some alcohol involved, and they don't like the history was very iffy. Yes, so she had a sclera, and then also we couldn't explain her renal function. And then on the CT scan, because then they were looking for other injuries, in the CT scan she actually had a glute infarct of sorts, but it was probably because she was lying down on the cement floor for so long, and no one knew how long. So she had tissue injury from just lying down and not being able to move, which is put us out a little bit.
Definitely. Tricky one. Old people.
Old people. She wasn't old, but she was drunk.
Well, she fell from the step. Yeah, I remember. That's the one. When we look at our urine analysis, a very important screening tool. So our myoglobinuria is diagnostic. So, but we have false positive results because I'm not able to really test that. It will pick up blood instead. But it's 80% sensitivity to detect rhabdomyolysis. But when you look at other causes of pigmented urine, it's taken into consideration. One of them, beetroot, is a funny one. Will turn your urine red. This happened to me once. Now as a student, it's scary. And for those that don't know, if you put methylene blue, your urine will turn green.
I probably will. Thank you.
And we take some blood. We look at creatine kinase. Less than 1,000 will exclude crush, and more than 2,000 is pretty suggestive of that. But our peak levels is usually 1 to 3 days post-trauma. But it doesn't really say if a patient's going to really develop acute kidney injury. There's some debate to say, more than 5,000 is going to definitely be it. But I've seen levels that are very significant without the development of acute renal injury. So again, more than 5,000 lower incidence, and even 16,000 is at 58%. That's not really a great number to work on. Yeah, more than 40,000, I guess you can say, probably. Myoglobin, we don't often test serum myoglobin levels. CK is enough and the urine is enough. And it's cleared more rapidly than the CK and less sensitive. Therefore, it's less sensitive. When we look at creatine-urea ratio, as I said, that creatine kinase is going to go up. When we have crush syndrome and the leak out from the cells, you're going to have a disproportionate levels due to rhabdomyolysis. Our venous blood gas is very important in the setting. There's been numerous studies that have shown with the predictive value of acute renal failure with soft tissue injury and in a venous bicarbonate levels. So if you have a venous bicarb of less than 17 on admission, you're going to probably develop acute renal injury. They said that from one of the studies, 80% of them usually require dialysis. I had a guy the other night, but very drunk. His bicarb was 17, and I thought, sure. I don't think he's there yet. He's still passing good volumes from urine, so he's then one of the 20% that didn't require it. So maybe.
Lucky.
And then again, with these factors of dehydration and sepsis and alcohol, then obviously the risk of needing dialysis is increased. The mortality of 59% with acute renal injury is present and 22% when it's not present. So that's pretty high numbers when you look at the picture. And if you imagine the building collapse and all those patients that develop crush syndrome, that's pretty big numbers we're looking at. Our management, we need to always think about pre-hospital management of the patient more. Early venous access and cardiac monitoring are very important here. Once you have venous access, they say give isotonic saline 1,000 liters, so 1 liter stat to the patients, and 15 to 3 mils per kilogram per hour. And if you cannot get the patient out up to 2 hours, then you need to reduce your fluids and monitor for any ECG changes if you can. After extraction, then you need to assess for other injuries. When you're in hospital, your management then starts. Your 8LS principles are obviously very important, and remember the temperature. Those patients that have been in the building for a prolonged period of time, or an old lady that has fallen, if it's cold temperatures, they can develop hypothermia, and that's going to also worsen your prognosis and renal injury as well. Your fluid resuscitation starts pre-hospital and need to continue in hospital. And we're going to have a long discussion about what fluids and how much fluid is needed. Then you need to correct your metabolic acidosis and electrolyte dysfunctions you need to look at as well. Early identification of the patients that require dialysis. Your surgical management, emergency fasciotomies, debridement of the necrotic tissue or amputation, and then delayed vac and skin grafting. But the fasciotomies only indicated when there is good indication for it. You don't just go willy-nilly to do a fasciotomy for these patients. Intravenous fluids are most important, and I've looked at numerous studies that are looking at what fluids be given. And Niels always debates upon saline versus Ringer's lactate. And in many different reports, everyone is going towards saline because they don't like the potassium in Ringer's lactate. Once the patient is in hospital, a catheter is important to monitor your input and output. So yeah, one of the few articles I've seen, this one and this other one about the fluid management, kind of concluded that your infusion should begin at a rate of 1.5 liters to maintain a urine output of 200 to 300 mils per hour. They said you replace with normal saline, no potassium or lactate containing solutions. That's what they want. If they're oliguric or anuric, once intravascular volume is replaced and the patient is euvolemic, then you can decrease your fluids to 500 to 2,000 mils over 24 hours. Life in the fast lane had this to say: they added 50 milliequivalents of Sodabek to every 500 mils of glucose to maintain urinary pH of more than 6.5, monitoring urine output, aiming for urine flow of 8 liters per day. And if bicarb produces a pH of 7.45, they say give acetazolamide and continue until myoglobin disappears from the urine. But again, this information is a bit controversial with the sodium bicarb. Again, many studies have been done not giving good support of the alkalization of urine, giving sodium bicarbonate and the use of mannitol. That's not really shown much benefit at all. So the use of sodium bicarb and acetazolamide and mannitol had been taught throughout to for alkalization of the urine and alkalized diuresis, but nothing has shown us good evidence, and these two also support that claim. As I said, sodium bicarb not being given, mannitol also, it's the idea that it's a free radical scavenger and an intravascular volume expander, not really much evidence to support that. Dialysis, again, it's only indicated as per standardized guidelines, which sure when we get there, the patient can get it. And our soft tissue management, early aggressive debridement, early fasciotomies, early amputation to decrease the burden of necrotic muscle. So building collapse, always keep in the back of your mind with those prolonged area of ischemic time, that they can develop these, yeah. The protocol that was given from Kevin, he developed one with Dr. Jacobs or Jacobs from Livingston Hospital. So they said here, and I think this guideline, which is probably going to be the best for us here. So resuscitate the patient according to 8LS guidelines, your ABCDEs. Examine the patient head to toe, looking at soft tissue injuries, and then your investigations, your FBC, UNE, CK, CMP, and ABG. Urine dipstics, look for blood in the urine or myoglobinuria if you can. Trauma series, x-rays, 2 large bores, and fluid resuscitation with the urinary catheter to monitor urine output. Continuing on, so you want to aim for a 30 ml per kilogram IV bolus, given at the rate of 1,000 mils per hour, saline or balanced salt solution. So they say balanced salt solution, yeah. So reassess the volume status, JVP. I don't ever look at the JVP when I volume resus. Pulmonary edema, again, it's a late one. And ultrasound or echo, I've never done that to assess to see if they're adequately being resuscitated. I think that an A line with looking at the wave pattern and early and late races is a good way to assess if the patient is fluid behind. Urine output, you're looking at 1 to 2 mils per kilogram per hour. You're going to repeat ABGs quite regularly, 4 to 6 hourly, to look at the potassium and calcium and then place it needed and correct your pH and bicarbonates. You continuously assess the patient's fluid status and blood results, replace calcium if needed, shift potassium if needed, and if need for dialysis, early intervention dialysis. And then this is actually just a brief breakdown on what they have. So if you're fluid overloaded, stop fluids, try to get dialysis involved. If your fluid status is normal, titrate the fluids, decrease the fluids, try and maintain good urine output. And that's about it. That's all I have.